Thank you, organizers and esteemed chair and dear friends. Thought of sharing two cases of angina. First is a 66-year-old male, euglycemic, hypertensive, non-smoker, walks 4 kilometers every day, LDL cholesterol baseline 168, had an unstable angina, 3 weeks of angina with activities of daily living, no rest angina, and resting ECG normal, resting echocardiogram is normal, EF is 58, treadmill stress test was strongly positive at 5 minutes with limiting angina. These are the angiographic appearances, and you would see that there is a proximal LAD significant stenosis. There is a borderline disease of tapering distal left main. Circumflex does not have any significant disease. As there's no scope for, within the time permitted for discussions, we'll go ahead. What would you prefer for this patient? Naturally, I think with patient with symptoms of angina and treadmill being positive, at very low workload, one would do a PCI for the LAD also. So that was done, and post-dilatation was done with a 3x22 DES was deployed, and with OCT optimization, the LAD stent was well opposed, and all parameters of optimal stent expansion was achieved. And this is the 5.8 and 5.88 is the proximal and distal ends of the LAD stent, and the MSA was quite appropriate. So would you plan anything more for this PCI after the LAD, having relieved the more critical lesions? But I went ahead with an FFR for the LMCA after the PCI optimization, which is important because if you have a suboptimal PCI outcome in the LAD, that would impact this. And certainly the basal PDPA was 0.89, DFR was RFR was 0.86, and LMCA to LAD FFR was 0.76. And you need to take all precautions of disengaging the guide catheter while doing the FFR because there could be an osteal dampening effect, and that should be done with equalization in the aorta itself with the pressure wire. So therefore, the OCT was done pre-PCI because one should be prepared to do the left main PCI in case there is a borderline lesion and you're attempting a downstream lesion also. So the significant left main stenosis with a thick circumferential calcification with a minimum lumen area 1.6 was 1.6 meter square was noted, MSA, minimum luminal area, and the MLD was 1.39. So the left main measured 4 millimeters. Therefore, there was a necessity to do a left main intervention, being a circumferential, thick, dense calcification, almost more than 300 degrees. The patient had a 4x12 shockwave lithotripsy, and you could see the distinct dark ballooning effect, which gave way with further shockwave pulses, and a 3.5x28 LMCA to LAD DES crossover was done, overlapping the previous LAD DES, and after OCT was done, and then optimization was done with the 4x8 pod balloon in the left main, and that was the final results. And this is the MSA at the overlapping edges of the LAD. You can see a multi-layer stent there. By the OCT, it was 7.7, and MSA in the left main was 11.5 square centimeters, and there were no malapposition, and there was good stent outcome. So it's important that we reassess any borderline lesion after optimizing any downstream lesions. The second is a 56-year-old gentleman from US. He's a full marathon runner for the last 7 years. He developed chest pain after running 7 to 8 kilometers, but he could continue to complete a full marathon with the chest pain without limitation. He has dyslipidemia with a LDL baseline of 178 on atorvastatin 40 milligram, normal resting LVEF, concentric left ventricular hypertrophy, being a marathon runner, and no regional wall motion. Exercise stress myocardial perfusion imaging was inconclusive due to the chronotropic incompetence at 11 minutes of workload. CT calcium scoring was 226, and coronary angiogram was done in USA. All this assessment was done in US, and he had a coronary angiogram, and it showed a left main disease of varying severity and 3-vessel disease. So the attending cardiologist who did the angiogram and assessed him advised a CABG surgery. He took 2 cardiothoracic surgeons' opinion from 2 different states in US, and opinion was divided. The first cardiothoracic surgeon said PCI to the OM and RCA, and second surgeon opined medical follow-up with no intervention at all. Because of the good physical endurance, NYHA class 1 angina, normal EF, stable anginal class symptoms, who could run a full marathon with a mild left main and mild LAD disease. So he came to India because his family lives in India for a final decision and did not carry the angiographic recording. He was willing to be reassessed. And these are the angiographic pictures before you. And you will certainly see that there was a borderline distal haziness of the LMC and a large OM disease, proximal circumflex disease. LED did not seem to have a major significant disease except in the second septal area. RCA had, after the acute marginal, there is a borderline stenosis. So what's your final decision? And he has come to us to nail the decision from our side so that there is no ambiguity in his decision making. So Fieron et al. Had published a very important trial and information that whenever there is only one major branch of the left main has a severe disease, as in this case the obtuse marginal, the downstream disease does not impact or make a clinically relevant impact on the evaluation of the intermediate left main stenosis with the pressure wire placed in the non-diseased vessel branch. So this is a DFR, 2 times DFR was 0.85, 0.86, which is significant from left main to LAD, and the FFR to left main from LAD, left main to LAD was 0.69, indicating there's a significant left main as well as perhaps an LAD disease also. So advised 3-vessel coronary revascularization, so he flew back to have his CABG surgery done in US. So the take-home message is that left main lesions are more often underestimated by the coronary angiography, and we have been traditionally following all this and making decisions on a critical impact of a disease in the left main on the basis of angiography all alone. 1 out of 2 left main disease as against 1 out of 3 in the non-left main disease would have ended up being misclassified when the classical 50% diameter stenosis of angiographic cutoff is used instead of functional assessment by FFR in the left main. And interrogating all the left main by physiological assessment is a good tool, and especially if there's a downstream lesion, you have to interrogate the left main after optimizing the PCI for the downstream, but you should be prepared to address the left main after doing the PCI. If you're not prepared to address the left main, then there will be suboptimal outcome. The current European guidelines indicate class 1 level of evidence A recommendations for physiological assessment by FFR or IFR. So all ambiguous and not so significant lesions, even less than 50% diameter stenosis appearing angiographically left main disease, should need a physiological assessment before a critical final decision is made rather than basing a decision on angiography. And subsequently, when you do the left main PCI, you should have an image-guided optimization of the various technologies that we have available for the optimized right port balloon with a desired left main procedural as well as a long-term outcome. Thank you for your attention.